This is the first session on the topic, which is very challenging to many of us when you have to deal with such a case. I have my co-moderator here, Dr. Vira. So I would like to start by invite the first speaker, Professor Minehara. He want to speak with us about the Masquelet technique for the treatment of large bone defect, how we can bring from the clinical and to the basics, and then use it in the clinical application. Please.
Thank you, Mr. Chairman. I really appreciate your invitation, and I also thank Concord and people for letting me stay here in such a great Congress. Learning objectives are understand the molecular and cellular mechanism of the induced membrane could help optimize the technique and prevent future failures. And also, as a fracture healing, inadequate fixation stability may negatively affect healing in Masquelet technique. So let me start with this case. 71-year-old male motorcycle accident hit by the car. This is my junior's case at my former hospital. And the patient had a left distal femur open fracture, 3A. This is the X-ray on arrival, and the debridement and external fixation and created a 6 centimeter defect. And with soft tissue problems, without problems. And then later on the day 12th, bone cement with antibiotics was inserted in the defect. And unfortunately, 5 weeks later, developed deeper infection. And then again, they re-debrided and then put a bone cement with antibiotics again. And after infection subsides, 8 weeks later, they put an autobone graft. But very unfortunately, 4 weeks later, again, development of another deep infection occurred. So they re-debrided and put a bone cement with antibiotics. And after infection subsided 8 weeks later, they put an autobone graft again. And then finally, achieved bone union, and now the patient is walking without pain. But this is such a clinical challenge. Why did this case fail? Multiple stage of procedures, yet poor outcomes, and grafts were wasted because of infection. But why? Was the induced membrane of poor quality because they did so many debridements, and was the induced membrane of poor quality, and did they truly follow the principles of Masquelet technique? So key question was that what determines the success or failure of the induced membrane in bone regeneration? So to improve clinical outcomes, we need to go beyond the observation and investigate the biological mechanisms. So to address the clinical questions, we turn to a control of basic research model using mice to study the induced membrane's properties. This is one of the researches we published before. And so the background is that the mechanism and the properties of the induced membrane remain still unclear. And but recently, the crosstalk between macrophages and mesenchymal stem cells, MSCs, has gained attention in the field of fracture healing research. And also the timing and duration of the inflammatory response generated by macrophages in the early stages of the bone healing is very critical. So macrophages also have an important role in forming the induced membrane in response to the foreign reaction to the cement. So purpose of our study was to clarify the expression of macrophages in the induced membrane in the Masquelet technique. Also, there is another research question. Does the fixation methods make any differences of macrophages expression in the induced membrane? So we used 6-month-old mice and created a bone defect with 3 millimeter and fixed with a locking plate and also nail using K-wire. There are 4 groups created: a Masquelet group with a plate, a Masquelet group with nail, and a control group, a non-spacer, and a back group who put the spacer under the dorsal fascia. And membrane and the granulation tissue were harvested at 1, 2, and 4 weeks. We also did a histological evaluation, and we did a quantitative real-time PCR for marker of M1 macrophages and M2 macrophages. M1 is they appear in tissue injury and induce inflammation, and the M1 shift to M2, and M2 secretes growth factors and with the tissue regeneration. So this is a membrane at 4 weeks. Plate, you see it with more stability, and you see the still membrane there. And by nail, less stability, you have a thicker membrane. On the X-ray, you can even see the callus formation. And control group, you see granulation tissue in between the fracture fragment. And also in the back group, you'll see the capsule there, like a foreign body reaction. So histology shows the plate. You see the getting thinner. The membrane is right there, here, getting thinner. And the nail, you see how thick it is compared to plates. But thick membrane doesn't mean good membrane. I can say that. This is the messenger RNA expression. So this is the M1 macrophages induce inflammation. You see the plate, in the plate group, there's significant expression there. Also in M2, for tissue regeneration, you see the significant expression in plate group. This is a good result. So discussion, you check the characteristics of each group's Masquelet technique. You created an induced membrane with having a bone marrow derived cells and a foreign body reaction. Control group only has a bone marrow derived cells. Back group only has a foreign body reaction. So this study tells that a plate group showed a distinct macrophage expression versus a control and back groups. So to establish induced membrane properties, both bone marrow derived cells and the presence of foreign body reaction are necessary. What about the crosstalk in fracture healing? The crosstalk may explain the efficacy of the Masquelet technique. So to promote fracture healing, you need to increase the number of macrophages. And as I think I told you, there's a M1 and M2 macrophage. So we have to shift the macrophage polarity from M1 to M2 to induce fracture healing. And also in this study, high expression of macrophages in the induced membrane compared to control groups. And there's a report induced the use of titanium spacers caused lower foreign body reaction led to inhibition of bone regeneration. So these findings suggest that macrophages and foreign body reaction play crucial roles in the Masquelet techniques. Spacer, I thought merely blocking tissue regeneration, but mobilizing macrophages actually. And in these membranes, we thought that simple sheath only against graft absorption, but actually there's complex roles in bone regeneration. So fixation methods and induced membrane. In a place group, there's a whole bunch of expression, the macrophage expression there with a better stability. Compared to nails, less stability shows not so much expression there. And that could tell with the MSCs, it's correlated with macrophages. So fixation stability is lower, MSC migration differentiation is lower, reported by Koike. And so our study suggests that similar to fracture healing, excessive strain in the Masquelet technique may hinder progenital cell migration and healing. So as a conclusion, our study revealed unique macrophage expression in the induced membrane compared to simple foreign body reactions or bone defect granulation. And the induced membrane established properties beneficial for bone regeneration by both receiving a supply of bone marrow derived cells and also occurring foreign body reaction. As in fracture healing, inadequate fixation stability may negatively affect healing. So this is my take-home message. Understanding the molecular and cellular mechanism of the induced membrane could help optimize the techniques and prevent future failures. And also, again, inadequate fixation stability may negatively affect healing in Masquelet technique. Thank you very much for your kind attention.